Here's a question I want you to consider. If an AI system could diagnose your cancer more accurately than a human doctor, would you trust it? That question isn't hypothetical anymore, and this video summarizes a paper I recently published that takes a hard look at where AI actually stands in medicine right now, what it can genuinely do, where it quietly fails, and what we need to fix before this technology becomes a standard part of your healthcare. Let's start with the part that sounds most like science fiction, but is actually happening. Developing a new drug is a notoriously slow, expensive disaster. For every drug that makes it to pharmacy shelves, thousands of candidates get screened and rejected over years, sometimes decades. A huge chunk of that time is just searching, running experiments on compounds to see whether they do anything useful, whether they're toxic, whether they actually reach the right part of the body. AI, specifically what we call machine learning, can compress that search dramatically. These systems can screen millions of chemical compounds in hours, flagging candidates that would have taken years to find by hand. They can predict toxicity. They can estimate whether a molecule will even make it to the right tissue. They're not generating perfect drugs from scratch, but they're doing the grunt work of early screening at a scale no human team can match. This is especially promising for diseases that have historically been hard to crack. Neurodegenerative conditions like Alzheimer's, where traditional drug screening has been painfully slow and largely disappointing. Beyond the lab, AI is starting to show up in the clinic itself. In certain areas, radiology, dermatology, ophthalmology, AI systems have reached diagnostic accuracy comparable to trained specialists. Skin cancer detection, identifying diabetic eye disease from retinal scans, flagging abnormal chest x-rays, in places where specialists are hard to come by, like rural areas, under-resourced hospitals. This kind of AI-assisted diagnosis could function as a genuine equalizer. Not replacing doctors, but providing high-quality decision support where the specialist just isn't available. There's also the paperwork problem. Physicians in many countries spend a staggering portion of their day on documentation, writing up clinical notes, drafting referral letters, dictating discharge summaries. AI tools can handle these tasks through natural language processing, and that could free up real clinical time. In Canada specifically, this is particularly urgent as we have chronic physician shortages, an aging population. We have emergency departments under serious strain. Even modest efficiency gains matter here. One of the more underappreciated things AI brings to medicine is the ability to find meaningful patterns in data that's simply too large and too complicated for humans to analyze. Think about what the modern healthcare system generates. Electronic health records on millions of patients, genomic sequences, medical imaging archives, continuous data streams from wearable devices. Individually, these data sources are already overwhelming. Together, they represent a kind of map of human health that we've never had access to before. Except we couldn't read it. Deep learning systems can mine that data for patterns. One application, predicting clinical deterioration. Models trained on hospital records have shown the ability to anticipate events like sepsis or dangerous inpatient decline early enough to actually intervene. That's a shift from reacting to problems after they happen to getting ahead of them. The implications for both patient outcomes and healthcare costs are significant. The same logic applies to genomics. Machine learning models working on large genetic databases are accelerating our understanding of which gene variants are tied to which diseases and which might be viable drug targets. We're talking about a level of precision medicine that simply wasn't possible before. Now, those are the good things. Now here are the problems. Here's where it's worth paying close attention. Problem 1. Bias. AI systems learn from historical data, and historical data in medicine reflects historical patterns of care, including all the ways that care has been unequal. If a diagnostic model is trained mostly on data from one demographic group, it will probably work less well for others who are not from that demographic group. This has already been documented. Algorithms used to allocate healthcare resources have been shown to systematically underestimate the needs of certain, let's say it, non-white patient populations, because the training data used prior healthcare spending as a proxy for health need, and spending patterns were shaped by systemic inequality to begin with. The concern that my paper raises isn't abstract. If AI gets widely adopted without fixing these biases, it won't just fail to reduce health disparities, it may actually deepen them. Problem 2. The gap between the lab and the real world. A model that achieves impressive accuracy in a controlled research setting often doesn't perform as well when deployed at a different hospital with different imaging equipment, different patient demographics, different documentation practices. When you're making clinical decisions, an overconfident model operating in the wrong context is a patient safety problem. This is especially awkward because AI has been most aggressively promoted for exactly those under-resourced settings where it might be least reliable. Rigorous, context-specific testing before deployment isn't optional, it's an ethical requirement. Problem 3. Automation bias. This one is subtle, but important. When AI tools are embedded in clinical workflows, there's a documented evidence that some clinicians will defer to the algorithm even when it's wrong, especially when the output is presented with high confidence, or when they're time pressured. We tend to assume that a machine that sounds certain must know something that we don't. This isn't just a problem of individual judgment, it's a design problem and a training problem. How the AI output is presented, what override mechanisms exist, and how clinicians are taught to engage critically with AI recommendations, all of that shapes whether automation bias becomes a systemic risk. Problem 4. Privacy and accountability. Training AI models requires large volumes of sensitive patient data. Aggregating that data across institutions and jurisdictions is legally complicated and varies enormously by region. And when something goes wrong, when an AI-assisted decision leads to patient harm, the question of who is actually accountable becomes interesting. Is it the developer, the hospital, the individual physician? This isn't well answered by existing legal frameworks. That ambiguity isn't a minor bureaucratic issue. It could meaningfully undermine trust in both AI systems and the institutions deploying them, i.e., doctors and hospitals. And finally, the human dimension. There are certain things patients need from healthcare that no AI, however sophisticated, can provide. Empathy, the sense that someone with lived experience in a body is listening to you. There are also real questions about workforce displacement, roles like medical scribes and diagnostic technicians that AI could take over, and what that means for people doing those jobs now. All of this leads to a pointed question about how we train the next generation of doctors. Physicians who don't understand how AI models work, how they're trained, what makes them fail, what their limitations look like, these people are poorly equipped to use them safely. And they're poorly equipped to advocate for patients when the algorithm gets it wrong. The solution isn't adding an AI elective at the end of medical school. Rather, we have to weave AI literacy throughout clinical training, not as a separate technical subject, but as part of how medicine is taught across every specialty. Practically, this means a few things. Radiology trainees should learn to work with AI image analysis and question its outputs, not just accept them. Internal medicine residents should engage with AI-generated risk scores and understand when they're likely to be unreliable. Students should be specifically trained to recognize automation bias in themselves. And future doctors need education in the ethical and legal dimensions. What algorithmic bias means for health equity, how data governance works, and what happens when AI contributes to a bad outcome. There's also an awkward irony. Medical students are already using large language models, tools like ChatGPT, for study support and case preparation. Educational institutions haven't caught up with guidance on how to use these tools critically. That needs to change. So here's where things actually stand. AI in medicine is not hype and is not a solved problem. It's a genuinely powerful set of tools in drug discovery and diagnostics, in finding patterns in population-level data that come with genuinely serious risks that we haven't fully worked out yet. My argument is that you can't treat the technical progress, the ethics, and the education as separate tracks. They're tangled together. How a tool is deployed shapes what ethical problems emerge, and whether those problems get handled well depends entirely on whether the people using the tools understand them. What that requires is progress on three fronts simultaneously. 1. Better technology. 2. Better governance frameworks. And 3. A healthcare workforce that knows enough to ask the right questions. The last one might be the hardest, but it's also the one we have the most direct control over.